You need. Oh, sorry.
The second opinion I'd really like you to write in a bit is that there's been some talk about doing Banff yearly instead of every second year. I've never wanted to do that because I was afraid that nobody would come. So I'm getting a sense, especially when I think that if all of us are leaving someone home to do the job that we like to do, then we only do it every 2 years, and there's some people who might only get here for something like this every 4 years. So please make sure you identify when you're filling in the form whether you're the full scope or the ESS, the operator delivery doc. Tell us what you think about the division, and please give me some thoughts about whether you'd find this useful as an annual program. The nurses are absolutely invited to opine on that latter question about whether you would find this useful in a more than every second year. So with that said, I'm going to turn you back to our rock star chair.
Thanks, Stu. So we'll be asking gently over the rest of the afternoon here to please fill out those evaluations because they help us make this event, I think, just better and better each year because it fits the people who come and attend and are hoping to get something out of it. So, you guys ready for the last session? Yeah. Okay. Early this morning you were way better, so I'm gonna, again, I coach basketball and soccer stuff, and so when I just don't get the response, push-ups, sit-ups, burpees, those tend to get the kids really riled up. So, how you guys doing? You ready for the afternoon? Yeah. Okay, all right. So, we have a renowned speaker here, Dr. Stuart Johnson, and I'm going to tell you a little bit about Dr. Johnson. So, he was raised in Zimbabwe, and then he trained in South Africa, headed over to New Zealand for a year, and then I think we hit the jackpot when he decided to come to British Columbia. He, for 27 years now, has been in BC. He's been in Banff, Gibsons, and now is currently in Oliver. Now, Banff, for those who don't know the BC geography, is a very comfortable distance from Prince George. So I have to say personally that I certainly miss having Stuart down the road and knowing that he's down there. He's also a prominent role in the Rural Coordination Center for BC, and I think you're going to start to see why when you see the amount of work that he's done. He has a particular focus in hand surgery, and he's certainly known for that. And even in difficult times trying to support the concept of ESS and GP surgery, I don't think there was anyone that really stood on solid ground if they ever questioned the work that Stuart Johnson did in hand surgery particularly. He also got training not only in South Africa, but he also sought additional training in Canada. And a lot of this hand surgery training was done at the Department of Plastic Surgery at UBC. And I think it really started to set the model of when you have that level of support. If you were to ask plastic surgeons in British Columbia what they thought of Stuart Johnson, they think the most highly of him as a colleague, not as a previous trainee, not as someone that came to do additional training, but a real quintessential hand surgeon that is a great teacher as well. But that's his surgical prowess, and that's what he's done. His history as an ESS, or the old days of GP surgery in northern BC and subsequently other communities. But I will say that there's, you know how we use a compass to follow in terms of a direction and where you want to go. To me, Stuart Johnson is a compass. He is someone professionally and personally, and just how he is with his patients and what they think of him, his colleagues in Vanderhoof, and the surrounding circle in northern BC. He is the epitome of what a physician is, not only in an operating room, but in their community and at large. So with that said, Dr. Stuart Johnson.
So, good afternoon. Thank you, Lily, for the compliment. So, I'm going to...
And my experience of them. And as I always say to any resident that I've worked with, surgeons are the very worst in terms of having fixed ideas that this is the only way that something should be done. And the trouble is when you leave the one who's doing the appendix this way and you go to the next one, you find it's totally different. So what I said to anyone that I've worked with is steal any ideas you like from me and build your own toolbox. Take the best from everyone that you work with and find what works for you. So I'm not always right. I certainly don't know it all. And I'm just going to share with you some of my thoughts from the years that I've spent doing it. And it started off in South Africa, where we were in the sugarcane growing area, and they used these machetes. And they would attack each other in the bar, and they'd put their hand up and they'd take out all 8 flexor tendons, and we called that a full house. And you would get a phone call saying you have a full house, and you'd groan because you knew you had 3 hours of work ahead of you. And after I'd been doing that for about a month, I got hold of the orthopedic surgeon, the consultant we had, said, you should probably teach me how to do tendon repair. So that's kind of how I started, and I've had nothing but kindness from the specialists in both South Africa and Canada, and I owe an awful lot to them for what we've achieved in rural BC. So one of the things about hands is a lot of people look with absolute horror when stuff comes in, and when you actually take a deep breath, it's not so bad. So this comes in and you think, oh my God, and you take a deep breath and you take your own pulse and you pull the fork out, and it's actually not so bad. So I can't tell you the number of times that I've seen an absolute mess arrive in the emerge, and I would suggest to you, those of you who have operating room, if it's a big mess, take them to the operating room ultimately and clean it up there. It's the kindest thing. You'll get the best outcome. And remember that what you guys do up front is hugely valuable. There's solid evidence now to show that the initial management will affect the ultimate outcome in terms of dexterity and all the rest of it. So let's start with simple stuff. You know, something like this comes in, you don't actually have to do anything. Basically reassure them, clean it up, and excuse, some of the photos are a bit out, and basically this thumb will quietly settle down. Someone asked me, are the whorls going to come back? Absolutely. I actually don't know. Does anyone know if the whorls are the same before and after? I've often wondered in terms of my police record. But so you know, when they come in, and as has happened a number of times, the old farmer takes out his hanky and shakes out the remains of his finger onto the table. You know, what I do is I just rinse it in normal saline and I put it back on. And, you know, this is now probably, I don't know, a week later, and it's kind of looking a bit soggy and white, and you're thinking, oh God. And 2 weeks later, it's looking like that, and you think, oh, I really am in trouble. Don't touch it. You're doing beautifully. And I don't have the final one, but the finger healed 100%. The other thing I would say, just a little aside, you'll often fix fingers and they'll look club-like and they'll look as though they've got chunks missing. Do not revise it initially. Tell the patient to go away and see you in 12 months' time. This is plastics. Don't fiddle. All you're going to do is put back more scar tissue, and you're going to start the 12-month period again. And the amazing thing with fingers is they remodel as they're used. And I've seen some horrible fingers at 12 months come back looking completely normal. So don't be in a rush to fiddle. Children fingertips, and the literature is interesting on this. Initially, they used to say, yep, you know, the kid actually literally, dad came in, she got a finger caught in the chicken coop, took off the tip, and it was just the bone spike sticking out. And he literally shook it out of his hanky, and which wasn't clean. And we washed it, put it back on, and it grew. And initially, they used to say up till the age of 5, you could do that. Now they say up to the age of 8. Now they're saying, actually, you can try it as an adult. What's the worst that's going to happen? It goes black and falls off. Start again. You're no further behind, other than time for the patient. So then you've got this. And these are the sort of horror ones when they come in, and they've either, there was a kid who did this by playing with a box of matches in a copper tube and trying to make a cannon and blew out the palm of his hand. But you see these sort of injuries, and again, when you see them come in, treat the patient, not the hand. So remember, this is trauma, ABCs, or in this case, bleeding. Stop that, because usually that's what's going to do them in. So get hold of that. And the other thing is, when you stop the bleeding, there's a trick that is really useful. And you don't just go in blindly with your mosquito, because you're going to grab nerves and you're going to grab tendons and you're going to do damage. So what you do is get the largest bag of saline you can find, and you take one of these things and you plug it in to your bag. You come down to this end here and you snap it off, and you've got your tap, and now you turn it on full bore and you've got a hose pipe. Take 2 if you need them. And what you do is you run this in until the blood has disappeared and you've got a pool of normal saline and you can see the blood puff of smoke. Now you can cleanly pick out all the bleeders. So you pick out the bleeders. I tie them off with chromic. You can tie them off with Vicryl, whatever you like. And I tag them. And I also tag the tendons. And now some of the plastic surgeons now, the more recently trained ones, said to me, don't bother about tagging the tendons. It's not necessary. I do it because, especially VGH, I've seen people lying for 2 days waiting for flexor tendons. They go north when you do that. And the other thing is, if I find nerves, I tag them. But if you tag nerves, 6-0, nylon. And basically what it does is it makes it easier for the receiving surgeon. So the other thing, let's just run through this. They come in like this, they're in huge pain. So the first thing you're going to do is very quickly, without trying to move it, you check both sides of each finger all the way around the hand and you record it. And the receiving surgeon will bless you for that. The next thing you do is you stop the bleeding. The next thing you do is you put in a wrist block and you get rid of the pain. And your screaming, writhing, uncooperative patient will become the best patient you've ever had. Then if it's a really bad one, I take them to the operating room. And then you can really clean them under controlled conditions. And it makes a huge difference. And roundabout within the first hour, 1 gram of Ancef IV, and get the TET tox in the first 3 days. But the gram of Ancef, again, there's discussion around this, but Greens, who's the Bible, says, give it. It works. Or if they've come in and they've worked in some crazy chicken plant and you think there's odd stuff, then give them the drugs you think they should get. But get it on board as soon as you can. And it's been shown statistically to improve the final outcomes. So you've done all of that, you've stabilized it, it's cleaned, you've got rid of all the nonsense. At that stage, you've decided this is a bit beyond you as a rural doctor. And so you're going to transport them. So in the meantime, while all this has been going on, you've been talking to your consultants. So I always say call for help locally, and then call for help distally. And I've spoken to many plastic consultants and I've had nothing but kindness. I explain where we are, I explain the time, and they've been great. Then what I do is I put one of these down on the table, I put the hand on it, I pour 500 mils of saline all over it so it's soaked. Then what I do is I wrap this like a boxer's glove, thank you, like a boxer's glove around the mitt like that. And then you elevate the hand. Now, it doesn't get macerated, thanks, Neddy, because all of the extra fluid runs out. But you've created a moist, warm environment, and the tissues love it. They really travel well. You've got hours and hours of travel. If it's going to be more than 6, I'd probably take it off, soak it again, and put it back on again. But you can travel for a long time. And another little tip, if you're avascular in any part of the fingers or the arm, we had a guy with a rock roll on here up in the Van der Hoof area, lost his blood supply. First of all, try to pull it straight. And quite often that disturbs the blood supply. But if that doesn't work, and you've got a long delay, remember, South Africa, we said 4 hours at their temperature before tissues died. Canada, do what, when in Rome, it's 3 hours. But if you've got a 6-hour travel ahead of you, you make a bed with plaster. What's I'm trying to say? Fiberglass. So, and then you lay ice into that. You lay one of these in, put the hand in it, put another one of these on top of the hand, pack it with ice, and wrap the whole thing. You've just earned the patient 8 hours if you do that before the hand becomes avascular completely, forever. And then you ship them out and send your note along. Tell them what you've done. Tell them what your findings were. And I've spoken to the consultants, plastics guys. They love it when they get that. Makes their job so much easier. So that was the end result of that case. And that's the function. So these are reasons not to go in and rip out vital tissues, not to damage vital tissues. Don't cut away viable tissues initially. You're playing for time. You should be shot if you refer something like that. I mean, you wouldn't refer something like that, obviously, but if you've got contamination. So a little trick here. You know those little butter patties and the mayonnaise things you get in the cafeteria? Get one of those, pop it open, it's sterile. And then just massage it into this whole area. It emulsifies it. And then you can take something and clean it up. And it works reasonably well. Chainsaw injuries were common up north with the logging industry. So this guy slipped and he took out his extensor tendons and he took out half of the second metacarpal as well. Beautiful little groove taken through it. So again, you record what's there neurologically. You check that you've got control of the bleeding. We took this guy to the operating room, and this was the resident who did this. He repaired the tendons. We've used another little tip. We stopped the bleeding from the bone, which can be a continuous ooze, by using bone wax. So we got the hospital just to order the little aluminum sachets, and you warm it up a little bit, get it out, roll it around, squeeze that into the exposed bone, and it stops the bleeding. And then you just cover up, try and interpose the bone. You don't want tendons lying on bone, they stick. And you ideally don't want tendons on skin. So you try to interpose with a bit of tissue. But for any of these injuries, you're doing the initial work, and quite often I've had some bad injuries where the stuff has adhered, and then I'll send them down the road to the plastics guys and say, please, can you, now that everything's settled down, can you mobilize the tendon? So don't think you have to cure them in one go. You're stabilizing them, and you're preparing them for a good outcome. Bench saw injuries, I used to say there were 14,000 a year. I just looked up the figures. In 2007 and 8, in the United States, they had 110,000 saw injuries. Pure bench saw 76,000 down there. In Canada, 30,000. So these are common. They brought in a new thing called a saw stop, which is really neat. And if you touch it, the saw stops instantly. And the worst you normally get is scratches. But they're not in yet, and you're going to see more of these things. So they're basically nasty injuries. And usually what happens, this one shows it a bit more clearly, what happens is they remove the extensor tendon, or they split the extensor tendon down the middle, and they open the capsule, and you can see the joint is wide open there. So this one, all I did was I went in with Vicryl, and first of all, you do the usual thing, clean it. I'm meticulous with debridement, so I sit with toothed Adsons, fine toothed Adsons forceps, and I pick out grass and grains of sand, and I work and irrigate the hell out of this. I use liters of water on this. And, so when you're finally happy, I put a big basin on the side, and I just swish this until it's completely clean. Then all I did was I closed the capsule with Vicryl, 4-0, undyed. The tendon in this case had been split. Some of it was missing. It wasn't too bad. Use a non-absorbable like Tycron or Ethibond. If you're absolutely hamstrung and you need to repair a tendon, you can use 4-0 nylon. It works fine. It's considered reasonable, except you're going to get the little knot sticking out. And years later, you'll come back and they'll say, please, can you pull this out? And it's reasonable to take it out at that stage. And so basically pulled the tendon back over the top of this, pulled the skin back over the top, and that was the final result. As one of my more cynical physician friends in Vanderhoof said, he said, Stu, that's a flexion picture. It's not an extension picture. So, but he did have full extension, I promise you. So this was a lady who was working a log splitter. And you know how you've got to have your hand on the button and on the lever. Well, she got her husband to hold the button so that she could work the log and the lever, and did that. So again, in the hand, thumb is considered to be 40%. If you've got a disability, you lose the thumb, you've lost 40% of the hand. Index finger, 20%. As someone pointed out yesterday, if you lose just down to the IP joint, that's considered only a loss of 5% because you've still got an opposable thumb. But the rule that I always say is thou shalt not shorten the thumb or the index finger as a GP. So if you can't figure out how to save them, I mean, if you have to trim a couple of millimeters, that's fine. But if you're talking of hacking off centimeters, you shouldn't be doing it. You should be transferring, because the specialists have ways of protecting the length. So what we did with this lady was we grafted. And there's something that, I mean, a lot of people sort of think that skin grafting is in the domain of the specialists only. It's not. There's a silver knife developed by Doc Silver in Toronto, I think it was. And there's a Humvee knife as well. And these things, I had a look on Amazon.co, that supplier of all medical instruments, $44, between 15 and $44 for one of these things. And what it is it's looks like an old-fashioned razor blade with a little roller in front of it that sets the gap. And you literally take the handle and you put it on the forearm, and you quietly saw your way up until you've got a big enough flap of skin, and it gives you a partial thickness. And they work. Clean it up, put them on, fenestrate it a little bit. You just put your flap on the table, make a few cuts and put it on, and you save them an enormous amount of healing time in this case. Someone also pointed out that, you know, letting them heal by themselves is absolutely fine. It is, and you get a wonderful result. It just takes a lot of time. Another little trick, if you want to know where the neurovascular bundle is on a finger, bend it, put a little dot at the apices of the IP joints there, and get them to straighten the finger out and connect the dots with the line. You are within 2 millimeters of the neurovascular bundle every time. And I've opened them up to find it and prove that. These are nasty. The kind of ones I've seen have been horse people where they've had their hand in the bridle and the horse is reared back and they've lost their finger. So there's still, if you're close enough to Vancouver or to, you know, Edmonton or wherever you've got really good plastics, and you've got the time and you can drop the temperature, there's a chance they can do that. The trouble is when they pull it like this, the arteries get stretched, they spiral, and they become very difficult to rejoin. So these are horrible injuries. And when you're dealing with patients, always deal with them, talk to them. Don't set them up with false expectations. Be realistic and say, this is a bad injury. I don't know if we can save your finger, but we're going to do everything we can. And once you've said that, you'll find, I found, they're much, much better to deal with. And whatever happens, they're going to be okay at the end of it. X-rays, obviously, old story, 2 views. You look at that and you think it's not too bad. You take the other X-ray, clearly it's not good at all. And here's another example. And the oblique begins to show it, and then the other one shows a horrible overlap as well. Now, in this day and age, whereas rural docs were always being told, don't call out X-ray unless you need them, don't call out the lab. When you get in court, I promise you that when you say to the judge, Doc, Your Honor, I was trying to preserve money, he's not interested. You're going to be hung, drawn, and quartered if you didn't do the right thing. And the right thing is to get an X-ray. Okay. If you have a non-healing wound, someone talked about this yesterday as well, and forgive me, some of you have heard some of these comments. X-ray it. It's an interesting thing. If you get a non-healing wound anywhere, it's worth X-raying it just to see if you've got some radiopaque body sitting in there. This is the Lukla Airport in Nepal. There's a 2,000-foot drop-off at the end of the runway, and there's a carcass of an airplane at the bottom, so it's quite fun. So finger injuries like this, if you're in the merge, some people just sort of, if you're flat out and dealing with everything, you might want to just bandage it up and send it to someone. But you can repair these amputations. This is the typical amputation. The first one I saw as clean as this. The guy on one of these semis was putting the legs down on the truck, and he couldn't get the pin in the hole, So he put his finger in to clear it, and then the leg dropped. And it was beautifully guillotined. So with these, you do a VY flap, and you basically create, that's your V, you mobilize that piece of tissue. You don't cut under the middle part of it because your blood supply and nerves are coming in. You move it forward, and if you move it forward 5 millimeters, you've done well. All I try to do is have enough movement just to cover the bone. And if I still can't cover the bone, then I'll take a pair of rongeurs and I just smooth the bone off. Never cover the end of a finger with a bone spike. It's really uncomfortable for the patient. So just get some bone rongeurs and just chew off the raggedy bone, smooth it off. And so long as you've got it over that, then the exposed subcutaneous tissue will heal very well in its own time. So that's the end result, and it's called a VY because you can see the sort of leg of the Y after moving the the flap forward. This is another one, and one amputation, one flap. In this one, I couldn't cover the tip. You can make a full thickness flap. This is taken out of the hypothena on the side here. Turn it upside down, take a pair of curved iris scissors, mow it like a lawnmower until it stops being yellow, becomes whitish, all the fat's gone, and then sew it on. And so what I did was rebuilt this finger like that. So to preserve length, VY flap, and then the tip as well. And that was the end result. So you've preserved length. He's lost maybe 5 millimeters. So these are all ways of just preserving length on index and thumb. This is a thumb. This you don't want to shorten. And just to show you, this is called a Moberg flap. Plastic surgeons do this. I do not. So they fillet it if you want. They bend the thumb down, then they can stretch it to the tip, and then with time it stretches out. So this is why I say talk to your consultants. They're a huge asset. This lady was cleaning a fish tank and got zapped by a lionfish, and huge agony. She came to me late. The treatment is heat. You put it into the hottest water she can tolerate without burning it, and you leave it there for 30 minutes, and the toxin denatures. Another one where you look at this and you think this was terrible. This was ripped off in a pulley. The neurovascular bundles were both completely intact. With the tip hanging like that, he could feel me touching the tip normally. So all you need to do there is straighten it out and put it back. So again, don't be in a hurry to chop things off. And that was the end result for that. That's Everest with the smoke on the top, and to the right is Lhotse. There's been some very interesting stuff recently in the last few years with frostbite with the use of TPA. So use anticoagulation stuff for these people. They also talk of aloe vera every 2 hours for the first 24, I think it is. You're trying to control the prostacyclin cascade, and again, these ones, don't be in a rush to cut anything off. You leave it for months, sometimes. Mallet finger, you use a stack splint, and basically it used to be 6 weeks, now it's 8 weeks, and you take it off, and if there's more than 15 degrees lag, put them back in the splint for another 8 weeks. They'll hate you. And you also tell them, do not for 1 second allow that fingertip to drop in the 8 weeks, because you'll start again. And it's true. So this is what's happened I don't know why I opened this, but you can see there's a complete disruption of the extensor tendon. That's what a mallet finger is. You should x-ray these things just to see if there's a chunk of bone taken off, because if there's more than a third of the articular surface affected, that's surgery. Jammed finger in basketball, typically horrible injury. You know, I was talking to the guys in Vancouver at the hand clinic. I said, how do you treat these? And they said, Stu, uniformly bad outcome, horrible injuries. Then I came across this, and this works really well, and in young people I've had good luck with it. It's an alu-foam splint. Those are 2 separate pieces strapped on and bent so that you can only open the finger to about 45 degrees or less for the first 2 weeks, and then first week, and then you extend it a little bit, and then around about 3 weeks you begin to open it up fully. And that allows the volar plate, which is torn underneath, to repair itself. Gamekeeper's thumb or skier's thumb here. It's the ulnocolateral. You can't test this properly unless you freeze it. So you've got to crank on it to see how much it'll open, and people don't like it. So put freezing in, go away, and half an hour later come back. If it will flex 30 degrees more than the other side, then you've got a surgical emergency that should be operated on in under 2 weeks. I used to always be terrified of using steroids on skin until we had a fantastic dermatologist come and say, that's absolute BS. He said, use the strongest stuff you can find and blitz it twice a day for 10 days. And ever since I've done that, I've had wonderful results. I've never thinned skin. I've never had a problem. And if it is not cured, I tell them, stop for a few days and do it again. So I use 0.1% betamethasone twice a day. And the other thing is some of them come to you and say, I've done that, it doesn't work. I say, no, it always works. And usually what they've done is they've, done. I say, you'll sit and you'll massage it in for 30 seconds. Then it'll work. Never fails. If you're using cream on the face, obviously go to something less. This was a petroleum thing again, steroids. You can give it, you can give prednisone if you want, but the cream will fix that. Be careful of where you're going. There's a thinner nerve sitting underneath that splinter, and you don't know if you snagged it. So it's perfectly reasonable in a situation like this to open it up properly and get to the bottom and see what you're dealing with. So the lesson here is just be a little careful of your anatomy. Things like this look terrible. You can see 2 barbs on the nail sticking out there, 2 barbs there. You x-ray it, you can see 2 barbs. So you know there's nothing inside, and you know that, I'm not showing you the other x-ray, you know it's outside the bone, just pull it out and treat him with his tetanus, obviously. Nail bed injuries are very badly done indeed. So if you get something in that you think might be traumatic, so this, you don't have a hematoma here, because subungual hematoma, because the nail's so badly schmucked, the blood's drained out. Lift the nail. The worst that's going to happen is there's nothing wrong. So you open the nail up, and there's the tear, and it goes up high. So I opened this even further. So right up, I repaired it with 5-chromic, and now you must flatten it, otherwise the nail will ride up. So you can put back either the nail, the original nail, cut the soggy end off, or you can put in an artificial nail. And we used to keep a box of artificial nails from the pharmacy, or take the foil packet, fold it in 4, cut a nail out. You drill the holes with an 18-gauge needle in the real nail, the foil, or the false nail. These go on for 2 weeks. You must take them off for 2 weeks. Otherwise, the new nail will bump into it. So it's a bad photo, but that's what it looks like, and the nail will come down. And this squamous epithelium under the nail bed is special. It sticks to the nail. So if you need to, you can transplant from the toes up to there. If you're working on hands, the reason for this, it's flexor tendon. Just to show you, you can create your own flaps by tying back onto the surrounding skin if you're short of someone to help you. The juncturii tendon, if you've got cut extensors and you test them, I press down on the fingers like a piano, and if one lags, then open it up. You're not going to be paid for microsurgery. Look properly and be careful, because sometimes there's these crossover tendons, the juncturii, and here's what a real one looks like, connecting. So sometimes that's all that's keeping the tendon going. So open it up and look properly. And just the last two actually. So what is this? Raynaud's. Absolute contraindication to using epinephrine in your local anesthetic. I did it on a patient who turned out to be a lawyer who specialized in personal injury, at which stage I realized we were in serious trouble. Actually, he was a delightful person. He did well. But if you do this, there is a way to reverse it, but be very careful. Be careful in people with peripheral vascular disease, COPD, and just poor circulation. But otherwise, you can pretty much use epinephrine wherever you want. And I mix mine with Marcaine long-acting 50-50, and it works well. And the last one is paint gun injuries or oil pressure. These things are an absolute emergency. You get this trivial-looking thing, but the hallmark here is enormous pain, huge pain. And the reason that this is so bad, if it's an oil product, almost guaranteed they're going to lose that digit. If it's a water-based product and you open them up, you might save them. The reason they're going to lose it, look where it's gone. It's gone in there, and it's up. It's passed through it's up into the top of the carpal tunnel already. So this whole thing will necrose and die. Those ones you should ship as fast as you can and get them out there. Elevate, pain control. If it was me, I would decompress the thumb and open it, just split it, and see if you can help it that way. And that's the end of it. Thank you very much. This is Tweedsmuir Park between Williams Lake and Bella Coola on the west coast of BC. So those of you who like horses, highly, actually, it's also in the top 4 hikes, walks in BC. Thank you. Thank you.
Thank you so much. Kind of mind spinning. You're in rural areas, and often the occupations that surround you fit those kinds of injuries. Our next speaker has already spoken today, but her last talk, the nurses weren't in the room and missed sort of a review of, it was a crash course in obstetrical nightmares in many ways. So it was certainly interesting. Dr. Jan Kristolov is, let me tell you a bit about her because of the people that weren't in the room. Until April 2017, she served as a site executive at BC Women's Hospital and Health Centre and the Vice President of Provincial Women's and Newborn Birth and the Provincial Health Services Authority in British Columbia. She's a clinical professor at BC's Faculty of Medicine and the Department of Obstetrics and Gynecology. And she has been working in the Canadian Network for International Surgery, which is what brings her to the podium this afternoon. In this organization, she's the director of women's health programming and obviously does a lot of work there. She is remarkable if you were to look at her CV. She's done multiple things, not only within the obstetrics clinical world, but also president of the SOGC, expert advisor to the Canadian Institute for Health Information for Maternity, on the BC Consensus Panel for Cesarean Birth, among many, many others. She's won multiple awards. I think the most recent and certainly one of huge distinction is the Order of Canada that she received in January of 2017. She's done, like I said, a lot of work, including establishing emergency obstetrical training in Africa. And we talked a little bit about where she's from. She's from Northern Ontario, actually just down the highway from my mom's reserve in Sagamok. So I asked her, she plays the harp. So we explained that to the audience that when she talked earlier, and I said, okay, so you play the harp, big deal. One of the many things you do with all your spare time that you must have because you don't really do much. And so she laughed, and I think a couple things. One is she sort of keeps Air Canada in business with respect to the amount of travel she does for her multiple Canadian or national representation and also the international work she does. I said, well, has anything ever happened on these trips? And we were talking, and I could tell that when she started off with a quote, and I got to use it, Jen, is, I'm a weird person. And so weird things happen to me. And she went on to explain in one example when she was in Africa and she was going with another gynecologist, and she was heading down to the lake one night. It was a little bit late, and they were heading down to the restaurant that was on the way. And she heard a snort in the bushes and looked over just in time to see about 5 feet away from her a hippo. And so for anyone who knows sort of the statistics in Africa, you would think that the most dangerous animal in Africa would be something like the king of the jungle. Far from it. I think the hippo, from last time I checked, is the most dangerous animal on the continent. So, but she survived. The hippo probably ran away because he saw her CV, maybe. I'm not sure. I was completely intimidated, as I am too. So welcome, Dr. Kristolov, and we're looking forward to your talk.
Thanks, Nadine. Well, no, it makes you feel like you intimidate me. I'm so glad to be here, but I'm just checking which mic is. As I explained earlier, I did send my slides in, but somehow they didn't get loaded onto the computer for today, so we're just going to take a second and flip over to the computer. Great. How's everybody doing? Good. Welcome to the nurses. I did the talk before last, just before the break, and had everybody up watching demonstrations with beef hearts and stuff like that. So, and after that, plus the hands talk, I don't think anybody's actually hungry. But yeah, I'm so glad to be here, and I have to say, I feel I am surrounded by so many amazingly talented people, and I'm in awe of Stuart for what he's done in terms of hands in the province and in Western Canada. It's amazing work, and it's really fantastic. So it was wonderful. I say that as a gynecologist. Hands scare me because I'm just not used to dealing with them. I see stuff like that. It's just always amazes me how the precision is wonderful. Anyway, I'm going to give you a quick talk about some of the international work we're doing. I want to tell you a little bit about the main organization that I'm working with right now, a little bit about what we're up to. But I want to put it in the context of what we really need to do in the world. And I think there's a lot of overlap with what's happening in the room and what everybody in the room is about.
Canadian context. Now, I really do believe in my heart of hearts that what we need to do as a system is look at capacity and how to build it in the places that it's needed. And to me, that doesn't mean that you put more services in Vancouver and then ship people down, or as Ivo was saying today, put things in Saskatoon and then ship people down. No, what we have to do is build capacity where it's needed and where people can access it. So kudos to everybody who's doing the work, the rural work, and the enhanced surgical skill work. It's critical, and I think it's the future of medicine, and I think it'll continue to evolve that way. So that's my little spiel. So the Canadian network, what we really do is we work to enhance capacity of surgery in low resource settings around the world. And we do that really because we feel as Canadians we have expertise, and that it's our responsibility to share that expertise. And I'll talk a little bit more about that in a minute. How many are familiar with the Lancet series on global surgery? Brilliant. It's a brilliant series, absolutely brilliant. But what it shows really is that there's a vast disparity. And I mean, there's a disparity in Canada between North and South, for sure, but when you look at the whole world, they specifically looked at areas of the world like sub-Saharan Africa and parts of Asia, where there is less than 100 surgical procedures per 100,000 population per year. So what we know in high-income areas of the world, it's 20,000 per 100,000, and that's actually probably more than you need, because there will be some plastics in there, and there'll be some face, there will be all sorts of stuff in there. But we know that the minimum you need for safety is over 4,000 per 100,000. That includes C-sections, that includes traumatic amputations, hernias, you name it. But the gap is math, and if the gap is massive, and if you do the math, you'll see that there's a need for thousands and thousands of care providers. And if you do the math, you'll figure out that really in any country in sub-Saharan Africa, you'll never be able to have trained specialist gynecologists doing this work. So who does the surgery? Well, sometimes so now I'm talking about East Africa mostly, because that's where I've been working the most. Sometimes there's definitely specialist surgeons in the urban areas of these countries. Sometimes there's not. There's one gynecologist, for example, in South Sudan in the country. Often what you'll find is that there are MDs with some surgical training, and in many areas the medical officers or assistant medical officers will have 2 or 3 years of training, maybe a little bit less. And I know that I have many African colleagues in the room that are very familiar with this. So like I say, there's areas like South Sudan that have less than 1 doctor per 100,000 population. So there's no way you're going to train enough doctors to do it. You have to look at training alternative providers. Now, that's not always popular, and I can tell you that sometimes we do get pushback, even from things like the International Federation of OBGYN, that feel like all C-sections should be done by OBGYNs. It's not going to happen, and it's not a model that would ever be sustainable. So just want to tell you a little bit about the Canadian Network for International Surgery, and I know some of you are familiar with it. So it started quite a long time ago now, actually 22 years ago, and it was started by a bunch of general surgeons. And it was done because they were starting to perceive this unmet need. And this is before we had the MDGs and everything else, but there was a need for that. And it was before all the good epidemiology that was done by Richard Horton and the guys at the Lancet, but we certainly knew that the need was there. So they started to give the first courses in terms of teaching people how to do hernias and general surgery procedures like chest tubes, stuff like that. And that was started in 1997. And since that time, there's been intermittent grants, and it's sort of gone up and down as an organization. But we did a full-scale expansion to exclude obstetrics in 2004. And that's why when I came on board into the organization and when I started the structured surgical obstetrics course. So what we believe, and I think I share, these are my personal beliefs, and I think I share this with probably everybody in the room, and that is that a life in rural Africa is just as important as a life in downtown Vancouver. And as Canadians, we are recipients of a very great privilege. We have a responsibility to share with the rest of the world what we have gained. And I really do feel that's true. And to sharing our knowledge, I think that sharing our knowledge is much better than sharing our expertise. In other words, if you go over and work for a couple of weeks and come back, it's not going to have the same impact that is if you go over and train a bunch of people to do the surgery and then leave that behind. As long as you have a sustainable model, and as long as you know people are going to continue to do it after you leave, you've left a legacy that's going to be useful for that country. And that's what we try to do. And that this arises from our responsibility as global citizens. It doesn't come out of guilt, and it's not charity. It's our responsibility as citizens of the world to do this. And we make that very clear to our partners wherever we work. So what we've done over the years, we create surgical courses, and I'll just go through those quickly. We do train domestically, and one of the things that I've been thinking about is I think there is some overlap with ESS, and I hope that we can develop a much closer working relationship as time goes on, and of course transfer of skills to our colleagues in Africa. So over the past 22 years, we've actually successfully achieved 12 customized courses. And I'm just going to list them, and I'm not going to spend a lot of time on that. 150 Canadians, some of whom are in the room, and African instructors, over 750, and of course, those people have trained 25,000 African healthcare providers. And we run courses not just for doctors, but also for surgical providers, for nurses and midwives. Our courses, there's 12 of them. I'm just going to go through them very quickly. The first is our course for midwives. Our second is the essential surgical skills, which is for general surgeons. The third is the SOO, the structured obstetrical course for obstetrics. There's other courses as well. The Safe Surgery Saves Lives is the actual quality assurance program that goes along with this. There's an osteomyelitis management program, burns, hernias, traumatic brain and spine injury, and as well as other courses that go along with that. More epidemiology and safe surgery courses. And the idea is that we not just training, but looking at the quality systems that surround the delivery of the services as well. The other thing that the CNIS has been largely responsible for is the Bethune Roundtable. How many people have been to Bethune? I think quite a few people. It's our international health meeting for people across the country that are doing international work. And it moves across the country on an annual basis. And last year it was in Halifax. This year it's in Edmonton, I believe. And so it's great fun. And we invite people from all over the world, although it's mostly our Canadian colleagues that come. And the other thing I just wanted to stress here is we always work with our colleagues in country. And the reason we do that is we know that we don't have the context, that so we'll work with the Department of Health in Kasulu, Tanzania, and we'll do it at the hospital with the people who are actually providing the services. So we're not parachuting in and ever doing it on our own. And if we're going into the bigger centers like Kampala, we're working through the departments of obstetrics or surgery or whatever. The basic components are always the same: learning the content, practicing the skills on models like some of you saw earlier today, low-tech models where you're practicing, and then only after that, taking it into the OR to the patient. So we work pretty hard, and we don't often get to go on safaris, but this is actually a picture I took outside the hospital in Kasulu the last time I was there. It's, of course, a zebra, who just happened to stop by and have a little munch outside the restaurant where we were eating. the famous beef heart. Some of you have heard me talk about this, but we know beef hearts are hard to get in Canada, easy to get in Africa, but we use them a lot, and so a lot of the suturing and various things that we do are on animal models, including goats, beef hearts, etc. Kisumu, Tanzania is a place where we've been a number of times in recent years, and these people are all assistant medical officers, and they're all providing C-sections in their communities. This is the cohort that we just finished with in Tanga, again, assistant medical officers. And the people in this picture are the only people who do cesarean sections in a large rural area of rural Tanzania outside Tanga in Tanzania. So we believe that perfect dots, we know that if you have great fundamental skills, it's going to actually cause less bleeding, less complication, and in the long term, lower mortality. And sometimes you can see our little monkeys. We always have monkeys or zebras or something coming to visit us while we do these courses. This is the Tanga Airport. You can see arrivals and departures. It's a little hard to see, but you can see that we're all, it's pretty remote and pretty basic, but it's, works really well. It's really easy to get in and out of Tanga. Accommodations vary. As you can see, that's my room at the hotel at just outside Kisumu. And the roads, of course, are not always a problem as well. In fact, transport is the #1 obstetrical problem in Africa, as I'm sure the Africans, people of African origin in the room would attest. And we do need all the help we can get. So, we did struggle with funding for a while, but I'm happy to say that we've had some success. And now we're working on digitizing these platforms so that we can actually have them on mobile devices and hand them to the care providers and leave them there. We're building a 6-month curriculum with South Sudan, which includes both surgery and obstetrics. We're working on a number of different projects. So the work is ongoing, and I have to say, it's the fact that we are able to do something in the face of the situation where that there's so much disparity in terms of capacity in the world. It's a tiny drop in the ocean, but every little bit you can do is helpful, and it's a great joy to be able to be part of the work. What you can do in terms of CNS, you can be a member, you can donate, you can volunteer, you can. But the other thing I think is just generally as members of the Canadian public, you can advocate for global health. You can advocate for the fact that we as a society really have a responsibility to share our wealth, both within our own country and with those around the world. So that's really all I want to say, other than thank you. And it's been a great joy to be here with you yesterday and today. And again, thank you for everything you do. Thank you so much. Yeah, I think we have time for one question. Oh, yes, so that's a very good question. Anesthetics in a lot of the small centers are done by nurse anesthetists. Most of them have skills in spinals, but not all. Some of them, there are places where all the C-sections are done under ketamine. Ketamine is very widely used, and so if you're going to have a general anesthetic, it tends to be ketamine, which, it's safe in some ways. It's a very unpleasant experience, though, for women generally, because they have nightmares and other things. Spinal is definitely better. So most of the time they try to have somebody in the community that has some sort of experience with spinals, and it's generally nurses. There'll be an anesthetist one anesthetist in Tanga, for example, but there won't be enough that to actually serve anything other than the major hospital. Great. Okay. Oh yeah, it's great.
When you take a look and think of the challenges that we have in Canada, to remember to look at things on a global scale as well. So our final session is actually going to be a panel. And what I think I'll do is I will, for the purpose of time, I think I'll introduce all three, and then I'll ask the panelists to each do their talk, and then we'll hopefully have time for some question and answers. This panel is about improving rural trauma outcomes. And the question is local damage control. So in no particular order, I will introduce Dr. Kirk McCarroll. As you know, already spoke this morning. Does anyone remember the acronym? He's the RCCBCFPANL. Do you remember that? Can you repeat it after me? RCCBCFPANL. Yes, he is the network lead. He was the GP anesthetist that so bravely stood up in front of us. And I think that he's shown us what the role of anesthesia is here at this conference because, of course, anesthesia, nursing, the surgeons, you can't have one without the other, and all of the patient needs all members of the party there. So we have Kirk McCarroll, and I have Brett Batchelor beside me. I said, what can you tell me about Kirk? And so you can, he had a lot of material, Kirk. But I think one interesting fact that he shared with us, and I think maybe in the break between dinner he can show us some pictures, but in his spare time, I think this summer he built a sauna on his property, and that sounds like a pretty good idea. So our next, another speaker is Dr. Vicki Voigt-Haynes. She has not been up to the podium yet, but is often at the podium at these events because of her role in ESS. She's been practicing in ESS since 2009, 4 years in Meadow Lake, Saskatchewan, and then in the last 2.5 years here in British Columbia, or Revelstoke, 4.5? 4.5, oh my gosh, that goes fast. An important fact here is she was the first ESS resident at the University of Saskatchewan training program, which really was the platform that the ESS momentum could be gained on because these graduates from this program were so successful and are changing really the reputation of ESS in terms of a real formal program that we are hearing about from the college's perspective. She's been an active member of the National ESS Working Group since 2012 with a particular input in the curriculum, and that would make sense given her role as the inaugural graduate. Recent involvements have also been a consultant for the privileging questions and the privilege dictionary for ESS here in British Columbia. She's a very adventurous lady. So one of the things that she does split boarding, you ask her what that is, and some downhill mountain biking, but those are the only two things she put down here, but I can tell you she's a very active lady. And our third panelist here, Dr. Richard Simons. I know personally because he was certainly a mentor of mine when I was going through my residency program. This is the bio that he gave. Quote, former trauma surgeon in Vancouver, currently a pear farmer in the Okanagan, which is in southern BC. Haven't worked in rural remote communities since the 1980s. Not sure why you invited me. So I can give you some reasons why we invited him. And this is a very, very pared down list, so to speak. Get it? Pared down, thank you. Oh, come on. Thank you. A pared down list. So he was indeed a general and trauma surgeon at Vancouver General Hospital. He's Professor Emeritus of the Department of Surgery at UBC's Faculty of Medicine. He earned his bachelor's, master's, and medical degree at an unknown or little-known university called Cambridge, and then did his residency in London, England. After a short time as a trauma surgeon in the Red Cross for Thailand and Cambodia, he moved to the United States and completed a trauma fellowship there and further training in trauma and general surgery at the University of Washington in Seattle. He then had a couple appointments at universities in the US, including Washington and the University of California, San Diego. And I think British Columbia and indeed Canada became incredibly lucky when he chose to come north of the border. While I was at Vancouver General Hospital, he actually established the primary BGH and in British Columbia a trauma system, but a trauma program. And the trauma program that he created trains not only the undergraduates and the residents, but fellows and the Canadian Forces in the medical trauma services training, which is incredible and I think very, very notable and has put Vancouver on the map. They have a strong research program because of the work they've done. He's the past president of the Trauma Association of Canada, the Royal College McLaughlin Galley Visiting Professor, and was recently awarded the Meritorious Achievement Award by the Committee of Trauma by the American College of Surgeons for his work in the trauma systems that he created, not only in BC, but the impact that had across Canada. Essentially, he's had an incredible impact. And I remember just being peripheral as a junior resident when he was trying to create a trauma system and the trauma program at BGH, and what that meant, and the battles that must have been being fought. As a resident, you don't realize what's going on behind closed doors. You just see sort of the impact of all of a sudden getting a lot more consults and a lot more focus on trauma. And then now being someone that's been practicing in the trauma system and being out there and realizing the impact that it has. I can't thank him enough for the impact he's had on Canada. And he is a huge, huge, huge supporter of trauma, no matter where it happens in Canada, because we all need damage control. All right.
It's over there. Swing this.
Okay, thank you very much. That was very gracious of you, Nadine, but you should have stuck to the script because you've used up all my time. So we're talking about trauma, and we're talking about damage control in the local environment. So 4 objectives for this panel. First is really just to highlight the issue, the excess mortality and risk of injury in rural communities. What, if any, is the potential role for rural practitioners in reducing that mortality? And then what are the networks and training programs that would need to be in place if we were to go that route? So I have the easier task, the first 2 bullet points there, and then fortunately Vic is going to pick up on the rest of it. I have no disclosures except to thank the Society for facilitating my participation here. So injury in Canada. So not an equal opportunity issue. So this is injury hospitalization rates in my province of BC. This is old data, but it hasn't changed much over the intervening 2 decades. What it shows is that in our rural jurisdictions, injury rates or injury hospitalization rates are 3 to 4 times higher than they are in our urban centers. Not news to anybody here, I'm sure. It's not a Canadian phenomenon. This is an international phenomenon. Any jurisdiction, high-income country shows the same data. This is the data for Australia, showing as you get increasingly more remote, then your chances of needing hospitalization or injury go up. So that's injury hospitalization. The data for injury death are even more compelling. So this is data we generated about in 2010. Showing that the injury mortality from motor vehicle crashes in the northern half of our province, which has about 1/16 of our population, is 5 times higher than it is in our more urban health authorities. And that data was in 2010. The latest data was from last year in the Provincial Health Officer's report, and it's now an 8 times disparity between urban and rural, so getting worse. Again, not a Canadian phenomenon. This is US data. Again, any high-income country that chooses to study this finds the same findings that we have. So we're dying more often, but dying faster too. So these are times to death in the different jurisdictions. Over half, 50% of deaths in the Northern Health Authority have occurred within an hour.
Compare that to those other 3 health authorities where it's in the range of 6 to 7 hours. That gives very little time to do anything. And not surprisingly, there's a delay that's freaking me out. Not surprisingly, where people are dying in rural communities is not in hospital. 3/4 of these deaths in northern BC are occurring before they reach hospital. So we have a problem. The problem is if you live in a rural community, you're more likely to be injured, you're more likely to die from injury, and you're more likely to die before you get to hospital. That disparity is not subtle. It's measured in several orders of magnitude, and it's been resistant to trauma systems development over the last 25 years. So you've heard that I've been involved in trauma systems throughout my career, and we've seen the gains that we've achieved in urban trauma jurisdictions, but we've really not been able to impact this rural death rate. So we should consider it a failure of current trauma systems. So we have a problem, we need a solution. If the solution was easy, we'd have figured it out by now, but we haven't. It's complex, we need a complex, multifaceted answer to it. We need better prevention, better targeted to our rural communities than it currently is. Yeah, we need improved pre-hospital care. We need to get patients out faster. The pre-hospital care needs to be better honed to keeping those patients alive until they can get to centers. But an important part of this is there a role for improved stabilization in the local communities prior to transfer, particularly if that transfer is of a length of time that's going to preclude survival. So what are people dying of in this? What are the preventable deaths that may be amenable to local intervention? Well, it's those deaths that are occurring in that 2 to 3 hours after injury, after the so-called golden hour. And it breaks down into 3 things: airway breathing problems, bleeding, and intracranial hemorrhage. So I'm not going to talk about airway. Most of the people in the room are better airway technicians than I am. Enough to say that trauma often poses some unique airway problems. Facial smashes, penetrating neck injury, or blunt neck trauma with laryngotracheal disruption provide some unique challenges that are not always amenable to your plan A or your plan B. And cricothyroidotomy should be part of your armamentarium. It won't get you out of everything, but it will get you out of a lot of these scenarios. Breathing problems rarely require urgent surgical intervention. The usual interventions that you're all familiar with suffice for the majority of patients. But I think bleeding is where most of the gains are to be achieved. And there's 2 parts of bleeding. There's the stopping the bleeding, which is obviously critical and what I'm going to focus most of my comments on. But there's also the resuscitation from shock, which probably a decade ago wouldn't have received a whole lot of attention. But what has happened in the last decade has been a true revolution in resuscitation and trauma care, and is making a huge impact on survival. So damage control resuscitation, you're talking to about that? Yeah. Good. So I won't talk much about damage control resuscitation, except to say that it's critical to survival from injury in rural communities. And if you've got a transient responder that you can't stop the bleeding with, you're in damage control mode, and you need to start initiating a whole different approach to resuscitation than the one we've been used to for the last 4 decades, and since ATLS came out in the 1980s. So stopping the bleeding. So here we got the good, the bad, and the ugly. The good is the easy, which is the extremity bleeding from lacerations, from fractures, from pelvic fractures that are all amenable to fairly simple but very important interventions to stop that bleeding as quickly as you can. And in that rare instance with a devastating extremity injury, you may need to use the tourniquets. So that's the easy bit. It's within the scope of most ED physicians and GPs practicing in that environment, and is certainly covered in ATLS and the Stop the Bleeding course. The bad, or the harder, is the junctional bleeding. This is bleeding from injuries around the axilla, the groin, and the neck. Harder to get control with direct pressure, although that's the first approach. But you may need to employ some other techniques, such as hemostatic dressings that have been available to military for a long time, but are coming into civilian practice now. And then catheter tamponade, particularly useful in the neck. So again, a lot of this is within scope of many of you practicing in emergency rooms. Again, covered by ATLS and the Stop the Bleeding course. But then we get to the ugly. So the ugly is the hardest. This is cavitational bleeding from 3 potential sources. So the abdomen, you pick this up with a positive fast in a patient who is hypotensive and is coming from liver or spleen or kidney or a torn mesentery in a patient who's got a seatbelt injury. The other cavity is the pelvis from a bad pelvic smash, ripping those posterior sacral veins, causing exsanguinating hemorrhage. And then thirdly, it's precordial injuries, presenting with usually with tamponade, not with exsanguination. So this stuff is outside of scope, right? So there's no one, I think, in this room who is comfortable doing any interventions aimed at tackling that. It requires obviously baseline surgical skills, but it needs specific trauma add-on skills to address this. Those skills are taught in another course called the DSTC course, but that by itself is probably insufficient for you to launch into this kind of practice. So what is these additional skills that we've been thinking about and talking about? The first is damage control trauma laparotomy. Now this isn't be able to do everything in the abdomen that a general surgeon can. This is to be able to go into an abdomen without being too scared and be able to manage hemorrhage as best you can. Now, packing is good for liver, usually controls liver bleeding. It may work for spleen, but it won't work for mesentery or kidney. There you need to do other interventions. The secondary goals are to contain contamination, but in a surgical first responder environment, that's really not a big issue. That can wait. But you want to get out of there fast and then get the patient rolling out of your door. So bleeding in the pelvis that doesn't respond to damage control, resuscitation, and wrapping, then your next intervention is a preperitoneal pelvic packing. Now, anyone who's done a C-section, it's the same approach. It's a suprapubic incision. You won't find the uterus, though, which is good because you don't want to mess with that. You go either side of the bladder and around the back of the uterus and into the sacral hollow, scoop out the clot, and then start ramming packs in. Don't go into the peritoneum, just start ramming packs in until you've come up to your incision, and then you close the incision. And then for precordial injury and tamponade, we've had some spectacular saves in this province over the last couple of decades from pericardiocentesis. But I'm sure there's been some spectacular failures as well. And if practitioners can be trained to be comfortable with ED thoracotomy, then that may be a better approach. But obviously that's an additional skill set. And then the last thing is intracranial hemorrhage and a willingness and capability to go in there and either do burr holes or craniotomy to save a patient who's in imminent danger of herniating. So those are the skills. How are we going to get them, or how could we get them? There are the basic interventions that we all learn in ATLS and Stop the Bleeding, or for nurses, it's the DNCC equivalent. But those aren't enough. You need the surgical interventions if we're really going to stop that cavitatory hemorrhage. And those are the ones listed there. Now, we can't teach those unless there's a basic level of surgical capability. And the presumption is, or the assumption is, that the ESS provides that, and that can form a platform on which to build additional surgical trauma skills to allow this damage control interventions to happen. So I'm done. Where are we with this? We're about to enter into a pilot project that Vic is going to talk to you about, and these are some of the other issues that we're wrestling with Unfortunately, I don't have to discuss. I can't see this because
I need the ears. I emailed them last week. Can we use my computer? Sorry, guys. So we all work in places where we have to deal with some types of trauma. I'm Vicki Haynes. I'm working in Revelstoke, and let's proceed. Amy, my colleague from Meadow Lake, where I worked for a number of years, just leaned over to me and said, "Are you guys getting a lot of gunshot and stabbing wounds these days? Our volumes are increasing significantly." And we actually don't in Revy, although we did have a stab chest last week that Kirk and Dries managed. We've got different kind of mountainy sorts of things, which most mountain towns would be familiar with. This is the vehicle of a lady from our community that a rock fell on in summer, driving by Three Valley Gap. You can see the hotel in the background there for anyone that knows that highway, and that was not the rock. This is a picture from another rock fall about 5 years ago. But yeah, funny things fall out of the sky around where we live, and sometimes it's the people that fall out of the sky because they're paragliding or rock climbing themselves. This is a lot of what happens around our highways near our little trauma bay. And in fact, those of us driving here yesterday just kind of missed one that happened west of Revelstoke, and you can see the tractor trailer of the other truck underneath that trailer there. And yeah, often, just like you, our teeny tiny little trauma bay and our teeny tiny little OR and our hopefully well-functioning, not too crapping their pants kind of cohesion teamwork helps us get through these cases. Our community is about 200K. If there's no road issues, no weather problems, it's not the middle of the night, we're 200K from our nearest trauma centers, Kamloops and Kelowna, and about 600 from Vancouver, where often we'll get the decision that the patient actually should be flown there instead of Kamloops and Kelowna. So it's really far. We check this Drive BC website every single time we leave the community, pretty much, more so in winter because half the time the highway is blocked and it's not really a 2-hour trip to Kamloops or Kelowna. It's a 4-hour trip or a 5-hour trip, or the team from Kamloops has to drive from Kamloops to Revelstoke to pick up the patient and then go back to Kamloops. And so it can be a 5 or 6 hour transport. Other things that happen in our community are crazy sports enthusiasts. This is Mr. Haynes up to his usual tricks. This isn't Mr. Haynes getting loaded into the helicopter, but I did take that picture, and that's my neighbor getting loaded into a helicopter at a mountain bike race. I just happened to be a couple of riders behind him and got to take his pulse and keep him happy while we airlifted him out to Kamloops. He was fine. These are the other shenanigan creators in our community. And sometimes this kind of stuff happens. Not recently, but I know Dries and Marty and Atsko were around for this incident 8 years ago, where 200 people at a snowmobile competition all were in the path of a massive avalanche, and our little hospital had to call every single doctor and nurse in the community to triage 150 injured people, 3 of which didn't make it. Yeah, so that's where I live, and it's an interesting place to be. Working out in the boonies, as we all do, is, yeah, you sometimes do get a little bit nervous. We are ESS trained folks who have a couple of interesting skills, which Richard outlined. We know how to open abdomens, we know how to clamp bleeders, and we know how to tie a few things off. I do wonder, as I'm sure most of you do, will there ever be a day that comes where I have to do things that I've heard about and even have trained in, like the cesarean hysterectomy, but have never had to do? Burr holes, you watch videos and it sounds technically simple, but like, when would you do that? And what if you are the last person and the highway's closed and you can't get your patient out? And something like that could really make a difference. I mean, that's why Jan is training non-surgical providers to do surgeries in very remote settings. We all know that this is a potential, and what if that moment ever comes to you? So even with general surgeons these days, there's gaps in specialist training with exposure to trauma services. There's hyper-specialization of general surgery. There's lack of time during many normal residency courses where you have an opportunity to participate in and see the broad spectrum of trauma cases that may come across your practice life in future. I think Richard well outlined the kind of the golden hour concept, where if you're in the city and your golden hour is 1 hour, there's many interventions that could save your life. That hour kind of extends to about 3 hours, I think I've heard, in the rural setting, where you've got, like, if you don't make it to the trauma center within a 3-hour period, your outcomes significantly decrease. So, Richard presented at this conference 2 years ago, and then at a Calgary rural and remote conference last May. And I think a lot of us that have heard his talks have been really impressed and intrigued. And one of the little birdies in the room was Stu Iglesias, as usual, who gets these ideas. And he once whispered to me, did you know that there's this course that the surgery residents can take called the DSTC, the Definitive Surgical Trauma Care Course? And I just thought, oh, wow. I wonder if an ESS doc would ever be able to take that, or even audit it, or like just sit in the room. And that's kind of what we're going to try and test. So Richard and his gracious colleagues, some really interesting, inspiring people, including the president of CAGS in Vancouver at VGH, and Stu and I have been chit-chatting over the last 8 months or so, and we're going to see if we can, we're making a little mini trauma fellowship. It will be at VGH. It will involve this course, the DSTC course, a course called Stop the Bleed. There's a wet lab, right? Pigs, yep, and cadaver, pigs and cadaver. And it will be designed to bring opportunity for experience in some of these potentially life-saving procedures to people that don't often get to see those cases managed. This textbook, in case you're wondering, I found free online, so I've downloaded it on my computer and I keep trying to read the whole thing. This Stop the Bleed course is a course that I didn't know about, but it will be part of the mini trauma fellowship, and I'll be able to take it and certify as an instructor. It's a layperson's course, from what I understand, designed to help people in the community, schools, swimming pools, etc., have first aid knowledge of how to stem hemorrhage if that should ever occur. It's funny, when you look on the website, you get the American versions of the Stop the Bleed course, and they say very clearly, like with so many mass shootings and terrorists in our country, that it's important that everybody take this course. So prerequisites: CFPC, ESS, CAC. When we're able to apply for the CAC, a current ATLS, and then a practice environment, your own community where it's a supportive place that something like a damage control maneuver could reasonably be attempted or supported with guidance from remotely counseling specialists. So we're saying fracture mobilization, diagnostic ultrasound, an OR, an anesthetist, OR nurses, and a recognized role of the small community's place in the rural trauma corridor pathway. The experimenting and developing that our community, like you heard from Nancy in Lillooet, is doing with clinical coaching and mentorship is really well related to this type of little mini fellowship. And we're hoping that we'll be able to bring remote presence technology in. And really, like, I think that remote presence technology, I suppose even if it's a telephone, which we all have, but the expanded video capacity of remote presence tech is going to be key to our exploration of this upskilling possibility. This was well outlined, but those are the clinical knowledge and competency components of the mini fellowship. The system objectives are, I don't know if I can say as important, just as important, more important, but crucial. Like, I don't think this little fellowship could happen without these well understood system objectives. Close working relationships with the principal players in our regions or provinces, trauma management trajectory. I really want to be able to know the faces and the names of the guys that I'm calling on the phone. And I think so often we really don't, and develop the relationships with people that can say, we know what you guys are doing, we know what you have the capacity to do, we can counsel you in a way that's relevant to this patient right now in this moment and to your capacity in your facility. Yeah. So I don't know how I get myself into these situations. I seem to volunteer for terrifying projects, and this is another one of them. I'm nervous. I'm going to go and live in Vancouver for 6 weeks, and Dr. Simons and his surgical colleagues are allowing me to come and hang out with them. So I'm going to do this DSTC course and the Stop the Bleed course, and then I'm going to hang out on the trauma service for 4 weeks and learn what I can learn. When I've talked about this with other people and explained it, I think it's important to clarify. I don't know if Richard is getting any of these kind of questions, but like, are you seriously going to be doing trauma laparotomies in Revelstoke all the time? And the answer is no, of course not. Not all the time. If I ever need to do a burr hole or a junctional hemorrhage arrest of some sort, I want to at least have seen it on a pig or tried it on a cadaver or done it once, so that when there's a guy on the remote presence tech monitor saying, Vicki, we have to do this, I'm going to help you, I'm going to tell you where to cut, that I've tried it once and I have good relationships with the people that are available to help us and our team and our community. So no, this isn't a mini fellowship to increase the cowboy perception of ESS. It's education. It's a pilot project, and we're all as an educational team going to figure out how we can learn. So I'm going to say thank you to Brett and Dries, who are going to cover the surgery call while I'm away, and our other colleague Cam that's at home. And that's me, the guinea pig. Thank you to the BC Rural Education Program. It's called the AST program, which is funding me to leave my practice for 6 weeks. And to Stu for constantly inspiring, interesting projects. I don't know how this works. Okay.
DCR. No, DCR talk right there. Thanks, Brad. You good, man? Awesome. Yeah. 5 minutes. 8 minutes. All right, I got about a 40-minute talk here. I was in 8 minutes. So, thanks for asking me to address you as well. And I'm going to talk about damage control resuscitation as opposed to damage control surgery. And that's because, contrary to popular belief, there are some other things that we can be doing on the other side of the blood-brain barrier after we select your playlist, adjust the table height, and check our email. So I really like this quote. I'm just going to read it for you. For damage control laparotomy to be optimized, effective early hemostatic resuscitation of the exsanguinating patient should be intimately coupled with surgical control of life-threatening injury. And unfortunately for you surgery folks, that means that for you to have good outcomes in your surgical patients, you're stuck dealing with us on the other side of the curtain. So I'm going to spend a few minutes here with my main message. Number one, trying to convince you that that information is in fact true. And I'm going to shift. I'm going to talk a little bit about the shift from conventional resuscitation that Dr. Simons mentioned to what we now call damage control resuscitation for trauma. I'm going to probably skip most of the information on most of the trials that discuss that, just for the purpose of time. And then I want to try and get to the discussion of how that would affect rural trauma care. So I'm going to take you back to medical school here, and everybody will probably remember this this classic death triad. Fantastic name. I love that. It sounds like something that should be on Star Wars or something. But you'll remember that acidosis, hypothermia, and coagulopathy are what ultimately lead to uncontrollable exsanguination and death of your trauma patients. And where conventional ATLS fails our patients is that it really, despite its good intentions of restoring intravascular volume, maintaining blood pressure, and ensuring end organ perfusion, it misses the mark in that with classic ATLS, we resuscitate blood loss with volume resuscitation. And when you do that, a lot of bad things happen. You dilute your clotting factors, you increase the blood pressure, which makes it more difficult for clot to form. And a lot of times it cools the patient. So this classic resuscitative effort, in fact, fuels this trauma-induced coagulopathy. So what we've discovered, mostly through a lot of the military experience, is that resuscitation with blood products is really the way to go. And this is a study here. A lot of these studies are retrospective initially, and then you get to a prospective a little later on. But some of the retrospective data is pretty convincing here. And as you can see with the overall mortality in these studies, is as you increase the amount of plasma that you're giving with your red cells, your mortality is dropping dramatically, or your survival is going up dramatically. So the American College of Surgeons Trauma Quality Improvement Program defined this concept of damage control resuscitation, and they've implemented it in a lot of the far forward combat hospitals in the war zones. And when they employ this damage control resuscitation, this is what they're talking about. There's 8 elements to it. The first is rapid recognition of coagulopathy and shock, and there's multiple scoring systems that are used to address that. And we use permissive hypotension, so we're not aiming for normal tension anymore. Rapid surgical control of bleeding, which you guys have discussed. Prevention and treatment of hypothermia, acidosis, and hypocalcemia, they're all very important. I'm not going to focus too much on that with this presentation because I really want to get to the other elements of it down below. So avoidance of hemodilution, so avoidance of crystalloid. If you can take one thing home today from the concept of damage control resuscitation, when it comes to trauma, crystalloid is really the work of the devil. You want to be using as little crystalloid with these patients as possible, and you want to go with an early resuscitation strategy with blood products. We're looking at a 1-to-1-to-1 ratio now, and for the most part, there's some debate over that, but most trauma centers would agree that that's probably the way that we want to go, and I'm going to present some of that data. Coagulation factor concentrates, and lastly, if we get time, it'd be interesting to talk about fresh whole blood. The first point, this is another retrospective study that was done in combat hospitals that looked at survival of patients, and what they did was they compared damage control laparotomies, and half of them were done with a conventional resuscitation, and the other half were done with damage control resuscitation. And you can see there the 30-day survival for the cohorts that were managed with a damage control resuscitation in addition to the laparotomy had remarkably improved survival. So you're stuck with us. Then later on in the United States, the PROMPT trial came out, and a lot of you are probably familiar with this trial, but this is a large study that was done in the United States that looked at 1,200 people in trauma centers, and they tried to show this benefit prospectively in a civilian type center. And in fact, they showed the same results that they're seeing in the military hospitals, that resuscitation with blood products is improving survival. And from that study, really what the question that came up is where exactly is the sweet spot? What ratio should we be shooting for? How many red cells, how many platelets, and how many plasma units should be given together? And I think that question was finally answered by this prospective randomized trial that was done again in the United States with about 11,000 patients. And in this trial, they randomized 2 groups to receive either a ratio of 1-to-1-to-1 with plasma, platelets, and red cells versus a 1-to-1-to-2 ratio. Interestingly, this proper trial was in fact a negative trial. When they looked at 30-day mortality, they didn't really see any difference between the 2 groups in 30-day mortality. But when they looked at the data a little bit more closely, what they did find with this ratio of 1-to-1-to-1 was that there was improved survival of those patients that were exsanguinating within the first 3 hours. And I think those are the patients that we're talking about here with local damage control, surgery. And the other thing that this proper trial proved was that using a strategy that used 1-to-1-to-1 had no increase in adverse events compared to a 1-to-1-to-2. So, and then other adjuncts, I'll just briefly mention, CRASH-2 has proven to us that within 3 hours, there's definitely benefit of TXA. There's a bit of debate about that in the literature right now, but I think it's generally pretty well accepted that that's standard therapy now for our trauma patients that are at high risk of bleeding. Calcium replacement, if you're giving lots of red cells, there's citrate in that and it binds you calcium. So you need to replace the calcium. Usually after about 4 units of red cells, you should be looking at their calcium because calcium is important for the pump, to pump. Oh, and cryoprecipitate, the other thing. Cryoprecipitate basically replaces fibrinogen. This is often given in a more of a goal-directed fashion. So in a center that's able to measure fibrinogen levels, cryoprecipitate is administered to replace fibrinogen. And there's lots of studies ongoing with that to look at that in a more of a standardized ratio as well. So that may be on the horizon for the future. Again, in the future, as we look at resuscitation, we talk a bit more about goal-directed therapy rather than blind ratios. So some of you may have read or heard about some of these point-of-care tests that attempt to identify which factors are missing, whether it's platelet malfunction or whether it's low fibrinogen, and then to titrate your resuscitation to what's missing. But that's the future, and there's trials ongoing right now to show whether there's a benefit to that over just a simple ratio approach. So I wanted to look at how this might look in our hospital, at Queen Victoria Hospital. And so I called our lab before we left, and I said, well, what blood products do we have, and would this damage control resuscitation be even possible at our hospital? So when I called them, I asked what our blood product situation was like. And if you look at our packed cells, it's really not too bad. We have 4 units of O negative, 4 units of O positive, 4 units of A positive, and 2 units of A negative blood. And we got 4 units of FFP, which is actually pretty good. You can really actually do a pretty good resuscitation with what you've got there, except for the fact that we have no platelets and there's really no cryoprecipitate. We've got Octaplex, and the role for Octaplex at this point in time is just for reversal of vitamin K antagonists. So if we look at a patient that's coming into Queen Victoria Hospital and we're going to consider a damage control surgery and we want to do a damage control resuscitation, how do we do? Rapid recognition, absolutely. We've got scoring systems that apply to rural, and I don't think there's any problem there. Permissive hypotension, absolutely, no problem with that. I think we can monitor these patients. We've got all the equipment and the know-how on how to do this. Rapid surgical control of bleeding. This is the work that you guys are doing, and I think that's commendable and a wonderful way to go. Prevention of hypothermia, acidosis, and hypocalcemia. We've tried really hard at our hospital to make sure that we're using warm products. We've got our bear hugger going, and we're dealing with that. And I think we can do that pretty well. Avoidance of hemodilution. We've talked about that, and that's easy to do. Here's where we run into issues. If you look at the proper trial, the first product that was actually delivered in the proper trial in the 1:1:1 was in fact the platelets. So we really are going to struggle in rural when it comes to trying to match these ratios that people are receiving in the larger centers. Coagulation factor concentrates, we don't have those either. We don't have any cryoprecipitate. That may be something that we can get. The challenge I might have with platelets in our small hospital is their short half-life. They only have got about a 7-day half-life, so that's always going to be a challenge. The final part of damage control resuscitation, which I think is really interesting, is this idea of fresh whole blood. And I wonder if that might be something for us to consider in rural. I know that seems like a crazy idea, but fresh whole blood has got many advantages over component therapy. This slide shows the relative effectiveness of blood products versus the fresh whole blood. And if you look at fresh whole blood, you'll see that it wins out in all factors. You're giving more red cells, you're giving more functional red cells, you're giving more platelets, you're giving better clotting factors, you're giving more fibrinogen. So so if we look at this, what about in terms of something that means something? What about survival? And they have looked at this in combat hospitals as well. And you can see here, this is another military, it's a retrospective study that's looked at lots of patients treated with either component therapy with a 1:1 to 1.3 ratio versus whole blood. And the results are actually quite striking, with improved survival at 24 hours and improved survival at 30 days. Of course, there's risk of infection. And in summary, damage control resuscitation needs to be coupled with damage control surgery to avoid the lethal triad. Most aspects of damage control resuscitation can be implemented into practice in a rural setting. Challenges remain with blood products. If we're really looking at novel ideas and we're trying to do something different in rural, and Nadine, you mentioned last night, I really liked your comment about we can be as good as them, but we can't be better. Well, I wonder if maybe in rural, with those good results we're seeing with fresh whole blood, this might actually be our chance to do something even better that they're doing in the larger centers.
to all three speakers. It's an exciting time, and certainly whenever we talk about the role of ESS in the rural surgical crisis that's happening in Canada and how we're going to address it, one of the topics that comes up time and time again is trauma and the benefit of having surgical capacity because of trauma. Remember in the beginning of the day, I said that I will be the most hated person in the room by the end of the day. I think I'm about to earn that title. Because given the time, I'm going to sort of not allow questions because hands are going to fly up and we don't have time to answer a bunch of questions. And so I'm going to say that after we wrap this up, ask the panelists to hang around for a few minutes for anyone that has specific questions. And then I'll hand out their personal cell phone numbers after that. All right, well, a couple things. One that's not on the agenda, but I think I'm really looking forward to this. Now, I hope I get the name right. Phil Stromsville? I would love to invite Phil up to say a few words. And I'm just going to say that Phil's a nurse that's been part of the entire day. And I got passed a note saying that she has a few words to say, and I think that that's most appropriate. We had anesthesia speaking, and I think and I know Stu's already said it, the presence of the nurses here has added an entire new dimension to this program. And I think this will be the last time that they're not specifically on the agenda sharing their perspectives, their wisdom, and their ideas. But Phil, can you just come on up and if you have any words of wisdom?
Actually, I don't have any words of wisdom. I just wanted to express on behalf of my nursing colleagues a huge thank you to Dr. Iglesias and the organizing committee of this program for extending an opportunity for us to attend this event. This has probably, and I've been in nursing for 45 years, so this has probably been one of the best conferences I've ever been to. So thank you for allowing us to be a part of it. It's been so informative, and it's been a great opportunity for us to network, to learn from other professionals, and because we all share similar circumstances working in rural settings, and it's just been a huge opportunity, and thank you for providing that to us.
Thank you, Phil. And really, really, again, I can't thank the nurses enough for coming and joining us here in Banff. So some final housekeeping. First of all, don't forget the evaluation forms. You always hear it at every conference, but I think this is one group, and the organizing committee, in particular, Stu and the work that he does, really look at these, and we want to hear your honest opinions, any ideas, and any thoughts about what we could add to next year's program to make it even better. So that would be greatly, greatly appreciated. There's dinner tonight, and the dinner tonight is starting at 6 o'clock in the Black Bear room. We are going to have a new set of great speakers up there with Dr. Markham, Bachelor, and Geller, and we're looking forward to hearing that. Talking about global surgery. Can it be win-win for both countries? And we saw a glimpse of that when Jan was up here talking about the role of the surgical network, the Canadian International Surgical Network. So we have that coming up for dinner. And then the final words, wanted to thank you for your participation, for coming to Banff, for being part of this initiative. And it's an amazing sort of sense when you get time and time again this many people growing every year, embracing the concept of rural surgery and the roles that we all have to play in the solutions. That I think we're making great strides to finding, to developing, to implementing, to evaluating, and being sometimes our own worst critics. But in that way, making sure that when we go forward even further, that we're doing it in a way that we know is going to be successful. So on behalf of the organizing committee, Stu, do you want to say any other words before we close off?
Just a big thank you to you, Nadine, please.
Well, we'll call it a day, and hopefully see most of you at dinner. And then, of course, for those of you who have signed up, there's the breakfast tomorrow morning. And take care. Safe travels to everyone, whenever you leave.